Good afternoon. I'm Bob Beasley from Mount Sinai Medical Center. I'm Director of Vascular Interventional Radiology and the Vein Center at Mount Sinai, as well as Director of the Wound Care Center. It's my pleasure to present today an update on mechanical thrombectomy for acute DVT with some case presentations. No disclosures. Deep venous thrombosis, as we all know, is clot or thrombus in the deep venous system. It can occur anywhere, but the vast majority occurs in the lower extremities. The symptoms include leg pain, swelling, tenderness, discoloration, and a palpable cord, which we describe as a thrombosed vein. About 50% of the people will develop post-thrombotic syndrome, which is a chronic lifestyle-limiting disease, which comprises swelling, pressure, pain, and ulcers due to valve damage and vessel damage. Nearly 90% of the patients are unable to work 10 years after iliofemoral DVT if it's not cleaned out. Evidence from the CAVIT trial and a signal from the ATTRACT trial suggest aggressive early intervention in iliofemoral DVT to minimize the risk and severity of post-thrombotic syndrome. There are many treatments on the landscape for deep venous thrombosis. Medical treatment is one, as well as surgical treatment. Today, we're going to talk about endovascular treatment. We're not going to talk about catheter-directed thrombolysis, which involves overnight infusion of catheters and ultrasound-assisted infusion of catheters. We're going to talk about devices related to mechanical thrombectomy and removal of the clot. We're going to talk about the JEDI thrombectomy system using the clear lumen thrombectomy catheter, the Indigo mechanical aspiration thrombectomy system, the AngioJet pulse spray thrombectomy, and the Inauri clot retrieval. We'll leave for another day to talk about AngioVac. It's a little more involved, and it's usually used in the operating room with perfusionists. The JEDI system. It's the clear lumen thrombectomy system. It's a powerful jet is inside the catheter mouth, and it macerates and dilutes the thrombus without safety concerns. In 2018 at CIRSE, an article was presented which showed that the clear lumen thrombectomy system was technically successful in removing clot in 80% of the procedures with no major or minor adverse events. This is an IVC filter case where you can see here a lot of clot located in the filter, all throughout the filter, and a couple of passes, almost complete removal of clot. Next is the AngioJet pulse spray thrombectomy system. It's by Boston Scientific. It utilizes the Zolante catheter. It's a large 8-French thrombectomy catheter to be used in the venous system. The mechanism of action is it shoots a stream of heparinized saline at 1,000 pounds per square inch across an open window. There's the open window, causing a Venturi effect. This macerates the thrombus and produces a suction for clot aspiration into the catheter and then into a collection bag. This is an example of a patient at Mount Sinai, 67-year-old male with left iliac vein occlusion from a previous stent. You can see the stent here is completely occluded. We were able to go through with a couple of passes with the AngioJet and completely remove a lot of the thrombus within the common femoral vein, the external iliac vein, and there's some still stuff located in the common iliac vein, which we were able to treat with angioplasty. The next system is the Indigo mechanical aspiration thrombectomy system. It utilizes the CAT8 device. This is Penumbra's system. It has a proprietary separator technology, which has mechanical clot engagement. It also has a large lumen aspiration, which maximizes the aspiration power. The tip directionality, as you can see here, it's angle, and it gets a lot of circumferential aspiration as well. And then it has multiple material transitions, which allows it to have advanced tracking. In addition, it has a large Indigo pump, which really gives us some nice aspiration power, easy to use with a single operator design, and it has a really, really nice vacuum, as I said. Here's a case from Mount Sinai where you can see a lot of iliofemoral clot extending all the way up into the cava. There's an inferior vena cava filter. We're able to use the Penumbra CAT8 device and continually go up through the femoral vein, up into the iliac veins, and all the way up into the cava with complete clearing out in the region of the clot. And then case 2, shows again a lot of clot located in the femoral vein, extending up into the common femoral vein and then up into the external iliac vein. You can see right here there's a narrowing, a really severe narrowing, probably related to this hip joint replacement, and then a lot of clot down here. As you can see, we used the Cat 8 device to come up from below. We were able to aspirate a lot of the clot, almost complete removal of clot from the iliofemoral system, and then finally treat with a stent placed in the common femoral vein. And then you can see the amount of clot removal that we had there. Here's another case, an 80-year-old female. She had common femoral and femoral as well as popliteal. Fresh thrombus, you can see through here. All through here, fresh thrombus, and then a large amount of clot located in the common femoral vein. We were able to take this penumbra device, Cat 8 device, come up from below, and you can see a very nice demonstration of the separator here, able to suck the clot out very easily using the separator. And we can see throughout the entire system, here's the clot, the device going up through there, sucking it out with complete removal all the way up into the area of the femoral neck and the common femoral vein. Next, we'd like to talk about the Inauri Medical Clot Triever Thrombectomy System. There's a collection bag and there's the coring element. It's used to separate clot from the vein wall, and the collection bag is used for embolic protection. As you see the sheath and the funnel right here, it's specially designed to ensure maximum clot capture. Here's a cartoon which shows it again. Again, it mechanically cores clot from the vein wall. It captures and removes a large clot burden from the big vessels, and it eliminates thrombolytics and ICU stay, which is a big cost to the institution. This enables a single session treatment with no capital equipment. And you can see right there that nice funnel sheath, which allows complete removal of the clot. We'll show a couple of cases here. First case is a 65-year-old male with history of recent left-sided left lower extremity DVT, significant edema and pain. Imaging showed clot extending from the common iliac through the posterior tibial vein. We had 4 clot triever device passes, 2 to treat the iliofemoral segment and 2 for the femoral popliteal segment. The total case time, including IVUS and stenting, was 90 minutes. You can see here a large amount of clot in the femoral going up into the iliac. This is acute thrombus. You can see the cast right there that shows it. After 2 passes down here with the clot triever, you can see a very nice removal of clot. It not only picks up acute clot, which you can see has this current jelly dark appearance, but also this chronic clot, which has more of a light appearance and is more rubbery in texture. Here down a little bit lower, you can see the acute thrombus and the thrombus, which was removed very nicely, almost pristine results with this removal of clot. And then this is the full spectrum, again, of clot removal that you can see. The really light colored rubbery chronic thrombus is easily removed. Really, there's not too many systems that can really take out this chronic clot like the clot triever can. Second patient is a 62-year-old female, had left extremity iliofemoral DVT confirmed by ultrasound. We gained access from the left popliteal artery using ultrasound with a micropuncture system. Intravascular ultrasound is used a lot in these cases. Almost all venous cases need to have intravascular ultrasound. It confirms sizing of the vessel for possible stent placement. It confirms clot location, and it also confirms May-Thurner-like extrinsic compression, which you can see pretty much up and down the entire iliac system at times. We used the device over a 035 Amplatz super stiff wire, and heparin was utilized. As you can see here, very nice, pristine results, again, with the femoral veins extending up into the iliac veins and up into the IVC. We did place a stent for treatment of a May-Thurner-like extrinsic compression, which was producing this original clot. You can see 4 passes, clot triever, all kinds of thrombus was seen here, the chronic thrombus and some of the more acute thrombus. 95% of the clot was removed as confirmed by intravascular ultrasound, and a stent was placed for compression, extrinsic compression for the May-Thurner-like disease. No TPA was utilized. There was no nights in the ICU, and only estimated blood loss was about 20 cc's. Here's a case 3 for the clot triever, a chronic clot case. Patient, 67-year-old, presented to the emergency room with a right extremity DVT. The patient had acute on chronic DVT. External iliac vein and common iliac vein was confirmed by ultrasound in the department. We performed right popliteal access as before using the ultrasound guided micropuncture technique. 5 passes were performed with the clot triever. And again, a lot of this was chronic clot. You can see here from the post imaging that we had a very nice result in the femoral location for removal of the clot. You see a nice result here with a stent being placed in the iliac related to the May-Thurner extrinsic compression. And again, there's a lot of this clot, which is extremely chronic, which really, I think, would be tough to be removed with too many other systems. Again, very little blood loss, no TPA, and no ICU stays. Another case that we just recently did about a week ago was related to a 54-year-old male. This patient had cardiac surgery about 2 to 3 weeks ago. Following the cardiac surgery, the patient had a pulmonary embolus. So we went in and cleaned out the pulmonary arteries using the flow retriever device. And after some discussion with the cardiovascular surgeons, we decided to place a stent. The patient was HIT positive, and we knew that, and that's why he developed the DVT and the pulmonary emboli. But we went ahead and placed the filter and used low-level agatroban. After the filter was placed, about 4 or 5 days later, the patient developed this large cable thrombus, which propagated and extended down into the iliac veins. The patient presented with severe phlegmasia and decreased pulses. Emergently, we came in and performed this procedure, iliocable thrombectomy. So with the patient in the supine position and frog leg lateral for bilateral popliteal access, we performed that. And then from above, we placed an 18-French 45-centimeter sheath via the right internal jugular vein and advanced it down through the stent. The reason we did through the filter. The reason we did this is because we had to place the clot triever device, and you do not want to use the clot triever coring element or the collection bag going through this filter. Obviously, you don't want to dislodge it or have problems with that. So we wire flossed through the popliteal vein, up through the right internal jugular vein, through this sheath, and then we used an Amplat super stiff catheter for the wire that we used to then run the clot triever device. We used 5 passes from the clot triever for each extremity. And then at the end, we used a 16-French flow triever, which there's a 16-French and a 20-French for removal of pulmonary emboli. This is the smaller device we used from the popliteal access to remove the remaining clot in the filter. Again, no TPA, no balloons, and no stents. Really, really nice, pristine result. Femoral, iliac location all the way up into the IVC. Here, IVC. We left the filter in place and we converted to high-level agatroban. And on the other side, you can see this very nice femoral, iliac, and then going up into the IVC. Next, and this is the total clot removed, which was a tremendous amount of clot removed here. And again, you can see there's most of this is acute, but there's a little bit of chronic stuff there as well. Next case is a patient that presented to us, had bilateral DVT with inferior vena cava involvement. This is a 62-year-old female who had neurosurgical procedures performed. Following neurosurgery, the patient became a high candidate for risk for DVT. The neuro IRs went in and placed a filter. The patient then recovered from this procedure, and the neuro IRs attempted to take out the filter. They were unsuccessful after 3 or 4 hours of attempting this procedure. And you can see here the legs of the filter are somewhat mangled as well. So following this attempt, the patient developed a clot, which occurred in the cava and then propagated down all the way into the popliteal veins. This patient presented up to us with severe leg pain, swelling, and phlegmasia. Although her pulses were intact, this was lifestyle limiting pain. So we brought her to our lab. And again, we obtained bilateral popliteal access, ultrasound guided micropuncture. We came from the right IJ using a 20 French Gore dry seal sheath. From the IJ, we passed it through the filter and then we used this as sort of a flossing device to where we didn't have to pass the filter and use the coring device or the collection chamber. So again, we put a glide catheter and a glide wire up into the sheath, and we externalized it. We had then an Amplatz wire, which we exchanged for, and we had flossing from the popliteal vein all the way through the right internal jugular vein. We then also gave heparin as noted. We had 5 passes on each extremity using the clot retriever from the IVC down to the popliteal vein with a mixture of subacute and chronic clot. 90% of the clot was removed as confirmed by IVUS, and you can see here very nice, pristine results in the femoral vein and up into the iliac veins on both sides. No TPA, no ICU night stay, and only about a 60 cc blood loss was determined. Here you can see the pre-IVC with the filter of the mangled legs, and post this, we have a very nice result within the IVC. We were able to take the filter out using endobronchial forceps through the sheath, and here you can see the filter with the mangled legs. Nice clot hull we can see there with acute and chronic thrombus. So in conclusion, these new mechanical thrombectomy devices, I think, represent significant advances in iliofemoral thrombus removal. I believe they'll lead to dramatic reduction in the percentage of patients that develop PTS and its devastating sequelae. Thank you very much.